Good evening, doctors. It's an absolute delight to hear three dignified and dynamic doctors here. Dr. Srinivas, Dr. Bhushan would be our moderator probably, and Dr. Nikhil and Dr. Bhaskar would be our speakers for the evening. And the topic would be dynamics of dry eye management. So I welcome you, and you can start the screen share and unmute yourself.
Thank you very much. Good evening and welcome everybody to this special session. I'd like to thank Santon for the invitation to be here and for helping organize this meeting. We are going to be talking about three important topics. The first is about a simple and clinical way to diagnose dry eye disease. I'm Dr. Srinivas. I'm from Chennai and I'll be doing that session. After that, we will have Dr. Nikhil, who will be speaking on the epithelium in dry eye disease. We now understand that the corneal epithelium is a key player in many of the events that happen on the ocular surface in dry eye. And so he will be talking about various strategies to help the epithelium regenerate and to keep it healthy, because a healthy epithelium helps avoid much of the morbidity that we see in a dry eye disease. Dr. Nikhil is from Bombay. He is in private practice after finishing his fellowship from the LV Prasad in his corneal program. And he has a very special interest in ocular surface disease and dry eye. And he has published as well in this area. And so we'll be looking forward to his talk on strategies for corneal epithelial regeneration. One of the ways in which we achieve this epithelial regeneration is by the use of sodium hyaluronic, which has epithelial healing properties in addition to its ability to function as a nice artificial teardrop. And to cover some of the recent literature and studies which show us the ability of hyaluronic to do this, we have the third speaker doing the last talk of this session, which is Dr. Bhaskar Srinivasan, who I think needs no introduction to an Indian audience. He is basically a senior consultant in the Shankar Nethralaya in Chennai. He works in a very specialized division of the cornea service there, the one that deals with ocular surface disease. And he has enormous experience in dealing with various complex problems of the ocular surface, including the use of the keratoprosthesis and other strategies to normalize the ocular surface. So his job today will be to tell us about the recent literature, which covers some of the aspects of sodium hyaluronic and its ability to treat and heal the ocular surface. So with this very short introduction, I think I will go on to the first talk of the day, which is by me, which is going to be about the strategies that we can use to diagnose dry eye disease. Just going to ask a quick question. Bhushan, can you see my slide? Can I start?
Yes, sir.
Yes, sir.
Bhushan?
It is.
Yes.
Yeah.
Okay.
Yeah.
Good. So I'm going to start now. So dry eye disease, the reason why we are talking about it is because it's becoming an increasingly prevalent problem in ophthalmology. It is one of the three most rapidly growing eye problems among the aged. And where we have reliable data, like from the US, it apparently accounts for 1 out of 4 visits to the ophthalmologist. We do not have such data pertaining to India, but the literature shows us that both the prevalence of dry eye disease and meibomian gland dysfunction is more in the Asians, and therefore we can assume from this that we are also seeing a significant burden of this problem in our clinics. This used to be a problem of the elderly, but with the increasing use of computers and the software professionals in the last decade or two, we have added a significant proportion of the younger group into this. And in the last 2 years, with the pandemic happening and with a lot of the education now being from home and online, the increasing use of video display terminals among children has resulted in a lot of them having similar symptomatology as well. And so now the burden of this disease spans the entire gamut of people, right from children all the way to the elderly. And therefore, it's worth spending some time looking at this problem in detail. Although we speak about dry eye disease in the context of tear film and tear volume, we must remember that the ocular surface is a fairly, there are a number of events happening on the ocular surface, and maintaining the ocular surface homeostasis is actually a fairly complicated process. Most of us take it for granted because we have comfortable eyes. But when you have dry eye disease, there is always a significant amount of inflammation that is present on the ocular surface. And whenever there is inflammation in dry eye disease, very quickly the meibomian glands get recruited into the mealy, and there is meibomian gland dysfunction as well. So if you do not treat the dry eye disease right at the start, meaning you do not take care of the tear film instability, you do not take care of the inflammation, and you do not take care of the meibomian gland dysfunction, very quickly it cycles up into what is called a self-perpetuating vicious cycle, brings in the other two, and over a period of time, the ocular surface becomes a hotbed of inflammation and other problems, and that is what most of us see in our clinic. So even though we are talking about it as dry eye disease, please remember that there are multiple things that are happening on the ocular surface that we must be aware of. One of the problems that we've always faced in testing for this particular condition is that there is no single gold standard dry eye and symptom. We also know that the signs and symptoms do not correlate very well. And most of us still rely on a clinical evaluation, this slit lamp examination, where we try and pick up the signs of dry eye disease to treat it. When we do perform tests to look at it, there are various problems because none of these tests have the absolutely required sensitivity and specificity. And even for the few that we do have and we perform them, if you look at the numbers, there is a big overlap between that for the normal and for the dry eye patient. For instance, a Schirmer value, although you have a cutoff, a Schirmer value of between 12 and 13 is neither here nor there. So you can't really say below that is dry eye, above that is normal. So we use cutoffs, but there is a range given in each given patient. And therefore, we believe that when you do more tests, we tend to get more data, and therefore we can segregate these patients better. We shall see if that is necessary. Now, the current evidence-based literature that we have for dry eye disease, which came out about 2+ years ago, is the DEWS-2 report. And they basically suggested that we ask a series of questions. And if these questions in the clinic seem to indicate that the patient has a dry eye problem, we do a formal estimation of his symptomatology using either the dry eye questionnaire 5 or the ocular surface disease index. And they've given you numbers, a greater than 6 score on the DEQ5 or a greater than 13 on the OSDI suggests a significant dry eye. And then they suggest actual tests. These objective tests include the non-invasive breakup time, although they do say that if you don't have access to it, you could use a fluorescein breakup time. Measuring the osmolarity, because these are the key markers of tear film instability, and ocular surface staining, which we look at on the cornea, the conjunctiva, and the lid margin. If any one of these tend to be abnormal, then we do conclude that there is a loss of homeostasis of the ocular surface. And then we go on to try and distinguish whether the patient belongs on the aqueous dry eye end of the spectrum or the evaporative dry eye on the spectrum, because we now believe that there's a spectrum and people exist within it. We no longer categorize them into two distinct compartments. In order to distinguish this, we have to do an anatomical evaluation of the meibomian glands as suggested by them, which is infrared meibography. We have to look at the output of the meibomian glands, which is the lipid layer of the tear film, and we have to measure the tear volume itself from the tear meniscus height. So these are the tests that have been suggested by the DEWS-2, which is the current gold standard, which therefore means that the evaluation of this particular problem is becoming increasingly complex. Because when you add fluorescein using a teardrop to dilute the strip and then put it in the eye, it's making it unphysiological, and we'd like to measure the breakup time on the surface without adding any tears to it. The NIBUT has come into force. So a grid that is reflected from the cornea, we look for breakup in the grid, and this machine will detect when this happens, where it happens, and this is the non-invasive breakup time. In order to give us a measurement of the tear volume, because the Schirmer has many limitations, it is suggested that you directly measure the tear meniscus. Again, requires a device and a highly magnified photograph of the tear meniscus. We also want to measure the lipid component of the tear film, and this requires a device that uses interferometry. To look at the anatomy of the meibomian glands, we need an infrared meibographer, and we can also document the redness score, which is suggestive of inflammation on the ocular surface. And all of this can be done by a single instrument, which measures, among other things, the blink completeness and so on. And it gives you a very nice composite report like this. And in order to basically measure the osmolarity, which the DEWS-2 suggested, you need a separate device, the tear lab device. And if you want to quantify the inflammation, the one way that we can do it now is to use the inflammatory device, which basically will measure the levels of MMP9, matrix metalloproteinase 9, on the tear film as a marker of inflammation. So the problem is Apart from this, the dues to recognize that also we're talking about the dry eye and the tear film. A number of ocular surface conditions can coexist, can be impacted by the dry eye, or can add on to the dry eye as aggravators and increase the burden of disease. And therefore, we must look for these as well. So our testing process must be designed to look for the impact of these various conditions on the ocular surface and the tear film as well. So if I were to quickly summarize this whole evaluation process, the testing that we do must help us detect the presence of a tear problem, must try and help us decide whether it's an aqueous deficiency spectrum end of the spectrum or an evaporative end of the spectrum, pick up the presence of inflammation, which, as I said, is coexistent in almost every dry eye, look for these other conditions which are shown on the slide and their impact on the ocular surface, and finally, the proof of the pudding is in the eating. We must know whether this dry eye disease is affecting the health of the ocular surface. So as we just saw a bunch of tests. I showed you an instrument which could do that, and then we added two more devices to it. All of this makes this whole process very complicated, very expensive, and we are having to use technology that is not very familiar to most of the ophthalmologists at this time. It's a time-consuming process, can take between 25 to 30 minutes, and we need a lot of equipment, and this becomes an equipment-based process. Since this is so important and we're seeing it every day, the question is there a simple technique that everyone can do which can help us achieve the same goals? And therefore, I'm going to try and look at ocular surface staining with fluorescein, which is very simple and which all of us do in our day-to-day clinics, to see whether we can use this as a measure of what it is that I was saying. So if you look at fluorescein in this context, it can definitely help you pick up the damage to the surface because the epithelium, which is unhealthy, will stain. We can use it to stain the tear meniscus, and while you can't actually measure it at the slit lamp, it can give you a good idea of whether this is reduced, normal, or elevated. One aspect that we didn't really speak about in tear disturbances is the tear clearance, or the ability the tear to turn over at a normal rate, and fluorescein can help you to look at the fluorescein clearance test, which helps you decide about the tear turnover. We can look at it in other conditions that affect the ocular surface, like in injuries and burns, infections which affect the surface, leaks from blebs, contact lens use and its deleterious impact on the ocular surface. We can look at the LASIK, where we actually cause neurotrophic changes, and in this case, there's an epithelial ingrowth. We can look at folds in the LASIK flap using fluorescein. Basically, this will again disturb the ocular surface, and if you have any elevated lesions leading you to suspect a tumorous process, fluorescein can again work with you. So in order to understand this process of fluorescein staining, we first have to understand some of the basics of this. So here we have the surface of the corneal epithelium, the flattened specialized squamous cells, and the corneal epithelium itself in cross-section is 5 to 6 layers thick, starting from the base up till the surface. And if you look at this cartoon, individual epithelial cells are joined by tight junctions. And here we have what are called the microvilli on the epithelial surface. These are projections which increase the surface area, over which you have the membrane-associated mucins, and together they form the glycocalyx. But once you go into the deeper layers of the epithelium beyond the superficial layer, we have gap junctions, which are more porous, and the importance of this we shall see. So when you see staining in the epithelium, what it indicates is there could be death of these tight specialized cells. There could be a loss of these loose junctions from toxicity, from medications, or from other disease processes, or the cell could have lost its glycocalyx, and in the absence of the glycocalyx, the fluorescein is able to stain it. Free mucus can stain, and once the dye gets past these tight junctions, it can diffuse through the deeper layers very easily. And one of the things that we use, the term is superficial punctate keratitis. So this is what we see on the cornea. And then basically when you look at the slide itself, what it indicates is either loss of individual cells, loss of tight junctions, or loss of glycocalyx, and that is why you get this fine spotty staining. Once the disease progresses a little more, apart from these, you can actually see some increased cell death as well. So what we're seeing is a loss of some of the layers of these cells. So instead of losing the entire cell layer, maybe 2 to 3 layers are gone. And therefore, you see a coarser or a larger area of staining. So this is called a punctate epithelial erosion. You can also get what is called a punctate epithelial keratitis, where instead of loss of cells, you see a heaping up of the cells. And this can be seen when you have an adenoviral or microsporidial lesion affecting the corneal surface. And the way to distinguish these slightly larger spots from the erosions is to do a slit. So here, because of the heaping up of the epithelium, this lesion will be convex, whereas in the erosion, there is loss of cells and it will be concave. And of course, when the disease progresses and the damage increases, you will see a loss of all the layers of the epithelium. This is the frank epithelial defect. And if you look at the surrounding epithelium as well, you can see the lack of health and the shattered right reflex, meaning that it's a very roughened epithelium. You can get transient spotty staining in a normal epithelium as well. And here it is because a senescent cell or an aged cell undergoes programmed cell death or apoptosis. Because it is programmed, even as it is dying and shedding, the underlying cell has taken up its role. The tight junctions are formed. So you may briefly see a small area of pooling in that area, but this will very quickly go in and take care of it. As opposed to this, on the right, you see pathological staining, where it's a necroptic cell death, where it dies with a lot of inflammation. And since this is a sudden event, the underlying cells are not prepared, and the dye is able to very quickly diffuse through the gap junctions in the deeper layers, and you see this larger area of stain when there is disease. When you have fluorescein on the surface, when you have too little of it, obviously there is no fluorescence. And as you increase the amount of fluorescein, as you can see in the tear meniscus here, the fluorescence increases. But paradoxically, as you look at this slide, as you increase the concentration beyond a certain point, again the fluorescence decreases. So if it is less than 0.01%, there is no fluorescence. But if it is more than 0.25% as well, there is no fluorescence. That is because in a very densely packed fluorescein stained tear film, the fluorescein molecules tend to absorb and cause interference of the reflected light, and you don't see it well. So somewhere in between is the sweet spot, which is 0.1 to 0.2%, somewhere here at the peak of this curve. And therefore, what you need to do is to put 1 microliter of the 2% fluorescein on the strip, meaning a very small amount. And this will get diluted in the 10 microliters of tears on the surface to give you the ideal 0.2%. So to remember, 1 drop is about 30 to 50 microliters. If you put this much of a fluorescein stained drop onto the surface, you're overdoing it. The ideal amount is that small amount so that the cul-de-sac and the normal tear volume of 7 to 10 microliters will dilute it properly. So just look at this video here. So basically, this is my clinic assistant with a normal ocular surface. So in the first instance, I've taken a drop of diluent on my fluorescein strip and I'm putting the entire drop into the cul-de-sac. So you can see here that there's a large amount of fluorescein that's going into the eye. The second is the ideal way to do this. I put the same drop of diluent on my fluorescein strip, but then I shake the strip vigorously and then touch and put a little amount of fluorescein. This is the exact amount that I want. So in this example, you can see that the tear film is stained with fluorescein, and therefore any finding there will be masked. Whereas when you put the smaller amount, you can see the fluorescence there, but you can see the surface of the cornea as well. So if there's any subtle finding in the cornea, we will be able to pick it up better. When we use light to excite the fluorescein on the ocular surface here, it will be nice if we can use the exact wavelength that will excite the fluorescein, and therefore we use a cobalt blue filter because this is the absorption spectrum, and that is what the cobalt blue filter allows to go in. After the excitation and the fluorescence, both the blue light and the fluorescent light are being emitted. And if you want to see the fluorescence better, you need to interpose a rattan filter, which blocks off, which allows the light only above 510 nanometers, which is the emission spectrum. So the blue light is blocked off and you can see the spectrum of emission better. This is a healing corneal epithelial ulcer. You can see a small area of staining in the center where the defect is still present with the cobalt blue fluorescein. But this is what happens when you interpose the yellow filter. Similarly, post-DALC, somebody who has dendritic viral keratitis, which is healing, you can see the dendrite breaking up with the fluorescein and blue light, but you can see it a lot better with the green light. And this is a last example of an elevated lesion staining with the blue light and with the yellow light. And this is an ocular surface tumor, which is picking up better. So the use of the yellow filter enhances the ability to pick up defects or changes on the cornea with fluorescein. But where it is really useful is when you're looking at the conjunctiva. When you use fluorescein on the conjunctiva and the blue light, we normally can pick up nothing because the blue light is intensely reflected by the sclera. So we use a dye like lissamine green. So when you use a dye like lissamine green, basically you can see the area of staining. You can get the same area of staining when you use your fluorescein as well. But in order to pick it up, you need the yellow filter. So if you have an yellow filter on your slit lamp, the only dye you need to look at the entire ocular surface in our condition of interest is fluorescein. You don't need a rose bengal or a lissamine green. Many of our slit lamps don't have these yellow filters, but these are fairly cheap devices, about 3,500 rupees. You can buy them from the net. And basically, this is held in front of the objective when you're doing your staining process. So when the light comes in towards your eye, you can use this to block off the blue light and see the enhanced fluorescence. So this is an example of what I was saying. You put too much fluid in the film, the fluorescein blocks this pattern. You have to wait for a few seconds for it to dissipate before you can assess the staining. Now this is a dry eye. I put the zero point 0.1 microliter here. There is not enough of tears to dilute it. So again, you have to wait for some tears to come in and dilute the fluorescein for you to see the entire picture. So too much fluorescein is not good. If you don't have enough tears, again, you have to give it some time. So the timing is also important. So this is before we put it in. This is by about 2 minutes. You see the exact fluorescein staining. This is the maximum amount you can leave. This is at about 4 minutes. And basically, this is at about, sorry about that. This is at about 12 minutes. You can see that the dye is extensively diffusing. So you don't want to wait too long once you put in the fluorescein, and you need to assess it or read the condition by about 2 minutes. This is a patient I've been treating for a Murans ulcer who came in with a recurrence of symptoms. I put in the dye, I see this. So I'm worried that his entire Murans is again recurring. But then if you stop and wash away this dye with some tear substitutes, you can see that the only area of staining is here. So here you have a crater from the earlier Murans where the dye is pooling. So with fluorescein, you need to distinguish between pooling and staining. Once you put it in the correct way and you've learned to assess it properly, then we have to have some kind of a grading that happens on this. So basically, we can use this kind of a division of the ocular surface into 3 parts. This is what Van Bichterveld suggested. You look at the staining score here, here, and here. Each of this goes from 0 to 3 so that you can have some idea of the amount of staining. 0 is no staining, 3 is extensive staining, and 1 and 2 are semi-quantitative in between for a score of 9. I also like to divide the cornea into 3 parts, the upper, middle, and lower 1/3, so that this I can also see not just the amount of staining, but the area of staining that is happening on the cornea. You can also use the dye to look at the upper lid. This is the lid viper area, which is the terminal 2 millimeters of the upper palpebral mucosa, which has the most contact with the ocular surface when you blink. And you can look for the line of marks on the lower lid. I've shown it here with rose bengal, but you can pick it up with fluorescein as well. This line outlines the openings of the meibomian gland orifices. So in conditions where you have meibomian gland dysfunction and the oil secretion is not there, basically this will tend to move further outwards towards the anterior border of the lid. The reason why we want to divide the cornea into 3 parts and look at the staining in each part is because if your staining is primarily in the lower 1/3 of the cornea, it indicates lid margin disease. If you have staining in the upper 1/3 of the cornea, this indicates some allergic changes, possibly due to upper lid disease. And if you have changes in the middle third or the exposed interpalpebral cornea, this is usually suggestive of dry eye disease. In a moderate dry eye disease, the uppermost 1 to 2 millimeters of the cornea will generally be protected because the upper lid tends to protect that area from desiccation. But if you see staining across the entire cornea, including the upper 1 to 2 millimeters, then you can think in terms of toxicity, possibly from preservatives of the drops that you're using, because the preservative and the drop will get into the tear film, go under the eyelid, and stain the entire area as well. In the conjunctiva, we can look at the upper one, the bulbar conjunctiva, because in superior limbic keratoconjunctivitis, this will stain from the frictional trauma from the upper eyelid. And if you have a conjunctivochalasis, which can interfere with the proper flow of the tear film and result in significant symptomatology, the traumatized conjunctiva will stain. I'm showing here lissamine green and rose bengal, but if you have an yellow filter, you can pick up these exact same changes with fluorescein itself. Medially, if you have something like OCP or canaliculitis, inflammation to the conjunctiva can be picked up. And temporarily, this area in angular conjunctivitis will be inflamed and will take up the stain. Like I said, in the lids, you can look at the upper lid. You can look at this lid viper area. You can look at the extent of staining as far as the width and the length is concerned to decide about the significance of the lid viper epitheliopathy in this particular patient. And as I said, this is the line of marks. And if you don't have the oil coming out of the meibomian gland orifices because of dysfunction, the tears can spill over further, and this line will migrate more anteriorly on the lid margin, telling you about the lid condition of the meibomian glands. So as far as the other correlations are concerned, when you put your drops in the eye, most of us put it in the lower fornix. And if you see this kind of an inflammatory state with staining of this little area of ulcerated conjunctiva, and if this ulceration and angry looking conjunctiva is limited to a line below, below a line joining the medial and lateral canthus, we tend to think in terms of a medicamentose. As you can see here, the superior bulbar conj is quite uninflamed. It's mostly here. So this was a toxicity from a medication. And in the early stages, if you see the corneal staining and compare it with the conjunctival staining, you will see far more corneal staining when you have a toxicity than conjunctival staining, because the cornea is generally the more delicate epithelium. The other correlation we can make is when the eye is significantly inflamed, when you have patient with extensive symptomatology, when he has significant redness of the ocular bulbar surface, but if you have conjunctival and corneal staining, which is very minimal, then this is a clue that inflammation is the primary pathology happening on that ocular surface. So we talked a bit about ocular surface staining. The question then is, how important is ocular surface staining? This is not necessary for every eye exam that we do. So somebody who comes in for a routine eye exam, probably we can do away with just a clinical evaluation and we don't need this. But when we have patient symptomatology that suggests a dry eye or other ocular surface disease, then as I just showed you, the staining can help you in multiple ways, detect the presence of the dryness and other issues, as well as some of the other conditions that may be happening on the ocular surface and complicating matters. We also do this because if you have a patient who has a known underlying systemic disease like rheumatoid arthritis, which is known to be associated with dryness, and he tells you, Doc, I'm a rheumatoid arthritis patient for the last 7 years, but I don't have any ocular problems, you still have to stain to look at the ocular surface, because in this kind of a disease, there is significant neurotrophic damage on the surface and the eye will look white, the patient will be asymptomatic. But many times I've been surprised when I put the dye, I get a score on the surface of 6 or 7 out of 9, meaning that there is already extensive damage in this quiet looking eye. The staining helps you to not just detect the presence of a disease, but as I showed you, depending on where it stains in the cornea, where it stains in the conch, where it stains in the lid, we can diagnose different disease processes. The amount of staining can help us grade the severity of the disease we are treating at that point in time. And when they come back after we basically treat them, we can prognosticate and monitor the progress of the disease and whether the treatment that we have subjected them to is doing the desired work and it's getting better. So if we look at the process of fluorescein staining that I've just spoken about over the last 20-25 minutes, what is the verdict? We'll go back to that initial slide that we started this talk with, saying that we wanted something that will help us to evaluate these patients who present to us, to detect the presence of dry eye, to look basically to decide whether it's aqueous deficiency predominantly or evaporative. We wanted to look for the presence of inflammation, try and diagnose the other conditions that may be operating on the surface, and finally detect the health of the surface. So basically, like I said, we can look at the volume of tears by the fluorescein stained tear meniscus. We can look at the breakup time, which tells you the degree of protection from the oil film on the tears, telling us how much of evaporative dry eye there is. We can use it to look for inflammation by looking at the fluorescein staining of the conjunctiva, because one of the important markers for inflammation is the amount of fluorescein staining. This has been shown in studies. We can look for the presence of other aggravating conditions, for instance, in this case, lid viper, superior limbic, conjunctivochalasis, and so on, as I just showed you. And the amount of staining of the all-important corneal epithelium will tell us the deleterious impact of both the dryness and these other conditions on the health of the ocular surface, which is ultimately what we are interested in. Because if you can keep the ocular surface healthy and keep the epithelium going well, then much of the damage that occurs and much of the morbidity can be prevented. So as far as fluorescein is concerned, this is basically a very simple test. It is inexpensive. Each strip costs about ₹1 last I checked. It is a familiar technique. All of us are familiar with it right from our first day of ophthalmic training. We've been using it. It's a very quick process. It takes less than 3 to 4 minutes to do everything with fluorescein. And essentially, no equipment is needed. Maybe if at all, you need to buy that 3,000, 4,000 rupee yellow filter to enhance your ability to look at the conjunctiva with fluorescein. But if your slit lamp luckily already has that filter, then you don't need to buy anything more at all. So in this first talk, in this particular session, before we go on to the other aspects of dry eye, we just wanted to focus on some simple objective way by which we can try and get most of the information, because I know in the Indian context, most of the general ophthalmology clinics which see a large burden of this disease do not have access to the sophisticated and fancy equipment that I showed you in the beginning. And so even without all of that, I think we can do a fairly good job in picking up the presence of this condition in our patients. So that's my half an hour that I had. So I'm basically going to stop here, and I'm going to invite Dr. Nikhil to do the next talk. Let me just get out of the screen and hand over the podium to Shweta, who's going to get Nikhil's talk online.
Thank you, sir. It was quite insightful. May I now request Dr. Nikhil Gokhale to come up and present their talk.
Thank you for giving me the opportunity. Today, I will be speaking to you on corneal regeneration in dry eye management, why it matters. We all know that ocular surface staining is a very important test, which is essential when we look at dry eye diagnosis as per the new studies. And it helps us to not only diagnose dry eye, but there are various staining techniques that we use in the process, such as the Fluorescein and the rose Bengal, to look at the extent of ocular surface damage with these dyes. It also tells us about the grade of dry eye. We know that a very mild dry eye may be having no real staining on the surface, whereas a patient with a more severe dry eye may have extensive ocular surface staining. So it helps us not only with diagnosis, but also tells us about the severity of dry eye. And once we know what is the grade of dry eye we are looking at, it also helps us to then decide what would be the most appropriate line of management for that patient. We know that dry eye is a very diverse condition. We have certain cases of dry eye where there is a lot of ocular surface staining. However, we also have a significant number of cases where the patients, though symptomatic, may not show significant ocular surface staining. So what are we looking when we look at ocular surface staining? Basically, on the corneal surface, we look at what we call as punctate epithelial erosions, which are basically a focal loss of surface epithelial cells. And these could be fine or coarse. And we also like to look at the localization of these erosions on the corneal surface. We know that in very mild cases, we might get punctate erosions in the lower thirds of the cornea. And in very severe cases, as the condition progresses, we can have a diffuse staining over the entire corneal surface. So why do we really get epithelial erosions in dry eye? And how does it help? So as I said, it helps us for diagnosis of dry eye, grading the severity of dry eye, for deciding what is the treatment that would be appropriate in a given dry eye grade, and also for following up the patients, because it helps us to know whether the patient is responding or improving following our treatment. And why do we get them? So there could be various factors. One could be mechanical factor, where we have frictional loss of corneal epithelial cells due to poor lubrication of the epithelial surfaces. And then we could have other factors, such as we know that there is a decrease in the subbasal nerve density in patients who have dry eye, especially which is chronic. And this results in a loss of trophic impulses to the ocular surface epithelium and also slows down the epithelial recovery. Cytokines on the ocular surface, because of ongoing inflammation in dry eye, can also lead to damage to the ocular surface epithelium. Patients with dry eye are also very sensitive to the toxic effects of medications and preservatives on the ocular surface. However, very often what happens is that when we look at treatment of a dry eye patient, it seems to be that we are only using lubricants and lubricants and lubricants. However, we should understand that lubricants have their own limitations. They are a palliative line of management and do not really address the core mechanisms of the dry eye disease. How do we address the epithelial problems in dry eye then? So as we saw earlier, we need to treat each of the mechanism which is responsible for causing epithelial erosions or epithelial surface breakdown. So for the mechanical problems, we need to improve lubrication, and best would be if we can use an agent which not only lubricates but also promotes epithelial regeneration. For neurotrophic factors and for inflammation, we need to use anti-inflammatory therapy, and we need to look at drugs which might aid neural regeneration. And to control the toxic effect of medications, we need to be very selective in what drops that our patient should be using so that the ocular surface stays protected. So what are our goals of therapy? Our goals of therapy is to reduce inflammation on the ocular surface and in the lacrimal gland, normalize the tear film, reduce the surface inflammation, stimulate surface healing, and improve the neural feedback loops. When we look at corneal structure and innervation, we realize that the ocular surface epithelium has a lot of tight junctions. So the corneal epithelial tight junction form a barrier. And in patients with dry eye, there is a breakdown of this barrier function. The ocular surface and the corneal layers also have a very rich, abundant supply through the subbasal nerve plexus. And in chronic dry eye, there is a breakdown or there is a damage to the epithelial and the subepithelial nerve plexus, and this correlates with ocular surface staining. How does our corneal epithelium really heal following a corneal injury? To understand this, you can look at this diagram, which shows us that whenever there is a corneal epithelial injury, it triggers the corneal nerves. The corneal nerves then release factors such as the nerve growth factor, substance P, and the calcitonin gene-related peptide. These further lead to a release of several growth factors, including the TGF-beta and the epithelial growth factor and others. And these then upregulate genes which activate and cause an increased expression of fibrin, fibronectin, and hyaluronic acid. The fibronectin helps to form a temporary scaffold over the bare corneal surface, and this also activates the edge epithelial cells to start migrating and adhering to the injured or wounded tissue surfaces. There is also an activation of the transient amplifying cells and the limbal stem cells, which then increase the epithelial cell proliferation and regeneration. And eventually the wound gets fully epithelialized. We know that there is a CD44 receptor which gets upregulated whenever there is corneal injury or there is a wound on the corneal epithelial surface. We know that hyaluronic acid binds to the CD44 receptor and promotes the corneal epithelial regeneration and provides hydration to the ocular surface, thus promoting the healing process. Once again, if we look at the wounded surface, as you can see on the picture on the left, there is an expression of fibronectin. The fibronectin deposits on the surface of the wounded tissue, and then the cells of the epithelium just next to the wounded area start replicating and dividing, adhering to the raw area and then spreading across to help the surface to heal. And once the surface heals, they start moving also in a vertical direction to provide us with the compact 5 or 6 layers of epithelium, which is there normally. Clinical studies have shown that whenever we use a combination of fibronectin and hyaluronic acid, or if we use hyaluronic acid in patients who have corneal epithelial breakdown, the binding of the hyaluronic acid to the fibronectin on the wounded cornea promotes corneal epithelial healing. As a corollary, patients who have non-healing epithelial defect may be significantly benefited by using drops which have hyaluronic acid, and this has been amply documented in several clinical studies. Several experimental and clinical studies have also showed us that the healing of corneal epithelial defects is significantly faster when we provide hyaluronic acid based drops to the ocular surface in patients with or in experimental situations where the corneal epithelial defects have been created. We know that there are several preparations of hyaluronic acid which come in different concentrations and different molecular weights. When you look at corneal epithelial healing, we realize that the healing is independent of the molecular weight of the hyaluronic acid molecule, but the concentration of 0.1% is most optimal in providing a faster regeneration of the surface. When we put hyaluronic acid based eye drops on the ocular surface, we know that the tear film breakup does improve for a period of up to 3 to 4 hours following installation. So by providing a healthy tear film for about a few hours following installation, we can say that if we use these drops 4 to 5 times a day during the waking hours, the patient will have fairly healthy tear film which is maintained on the ocular surface and will help to protect the corneal epithelium and give symptom relief to the patient. Let's look at how is the hyaluronic acid molecule behave on the ocular surface. So the hyaluronic acid is a sponge-like structure which has a very high affinity for water molecules. And just like a sponge, it holds the water and then slowly releases it into the tear film. And this can go on, as we said, for about 2 or 3 or 4 hours following installation. It provides moisture which uniformly then spreads across the ocular surface, maintains tear film stability and the wettability of the surface, and therefore improves epithelial healing because of the biological properties. Several studies clinically have shown us that in a wide variety of dry eye conditions, sodium hyaluronate 0.1% not only improves the symptom scores in these patients, but also reduces the ocular surface staining. And this has also been found in patients who have more severe varieties of dry eye, such as the Sjogren syndrome. Among the various polymers which are available for dry eye management, hyaluronic acid has the highest comfort index compared to the others. Therefore, when we look at a patient with dry eye who has an unstable tear film, using hyaluronic acid based eye drops not only increases the tear film stability and provides hydration to the ocular surface, it also accelerates wound healing and helps to provide a healthy epithelium on the ocular surface. Of course, whenever we look at dry eye management, in addition to the lubricating and drops, we also look at anti-inflammatory and other therapies. Use of cyclosporin, for example, reduces the inflammation on the ocular surface, and a long-term use of cyclosporin can also improve the neural regeneration on the ocular surface and cornea in patients with dry eye. One of the triggers for inflammation is epithelial breakdown, and therefore, just by the sheer fact that the hyaluronic acid can promote epithelial healing and protect the corneal epithelium, I feel that use of these drops may definitely help to also suppress inflammatory responses on the ocular surface. As I alluded to earlier, patients who have a normal ocular surface health probably can use several drops several times a day for a very long period of time without having any problems on the ocular surface. However, when we look at a surface which is not healthy, for example, a patient with dry eye, their surface is going to be much more sensitive to the use of any medication, and they often end up in getting ocular toxicity, which might manifest with an increase in ocular surface staining. Therefore, we need to be selective and we need to be cautious when we are using medications in patients with dry eye so that we can reduce the number of preservatives that we load on the ocular surface and reduce the use of toxic surface medications. And as science progresses, I'm sure that we would like to see less and less of ocular surface staining. And we hope that with better treatment modalities in the near future, we would be able to have a zero ocular surface staining in patients with dry eye, giving them an excellent quality of vision and an improved quality of life. And this would be something that we all hope to see in the future. Thank you all for your patient listening. Thank you.
Thank you, Dr. Gokhale.
Thank you.
Can we
Sorry.
proceed, sir?
Thank you, Nikhil. Yes, thank you, Nikhil. I think for those of you who are listening, there is apparently a Q&A box that is available on your screens at the bottom. So we will be taking questions. We will have definitely 15 minutes or so at the end of the session to answer questions. So please keep typing those questions in as you, whatever comes to your mind. And then we'll address all of that at the end. Nikhil will be there after his talk for the question session. Let me now invite Dr. Bhaskar, because Nikhil highlighted the importance of hyaluronic acid in regenerating the epithelium, and Bhaskar will try and share with us the current evidence that this is indeed so. Bhaskar?
Thank you, sir. And I would like to thank Santan for the opportunity. Let me just share my slide. So basically, what we are looking at in dry eye patients is something beyond just a symptomatic relief that they have by putting some lubricating drop in their eye. And I would like to thank Santan for providing the slide deck for this talk. So when you look at treatment options as far as dry eye is concerned, you have a multitude of treatment. You can start off with strategies, you can have various tier supplements, and of various tier supplements, you have n number of brands with n number of molecules. You can look at options of how you would want to do a procedure to retain the tears on the ocular surface. You could look at specialized contact lenses. You could look at biological tear substitutes or tear simulators. And you have a significant number of patients where you would be probably looking at some kind of an anti-inflammatory therapy with probably low dose corticosteroid at some point of time versus cyclosporine A or levetiracetam as such. But when you look at all these treatment options, you need to know where you would want to position which treatment. And that to a certain extent, DUCE 1 has given us a reasonable guideline as to how you would go ahead with prescribing medication. So if it's a step 1 dry eye or a very mild dry eye, you're basically looking at environmental modifications, and you could use any lubricants. And if it is an occasional use of lubricant, even those with a little bit of preservatives is not going to be that harmful to the ocular surface. The step 2, where your frequency of lubricating drops is more, is where you would definitely want to shift over to either a disappearing preservative or a completely preservative-free formulation, or a formulation which has preservatives which is less toxic to the ocular surface when used on a repeated basis. Step 2 would be the time that you would even look at anti-inflammatory treatment modalities, whether it is levetiracetam, whether it is cyclosporine. In an Indian context, you also have the option of using topical chloroquine, even though the published literature is not significantly available, but that's something that we do have. Again, you would look at antibiotics, which could take care of the blepharitis. You could look at tetracycline for its anti-inflammatory effect also, especially when it is associated with the rosacea-induced blepharitis and dry eye disease. And you would look at temporary plugs. And this group, you can even look at if the MGD is significant, you would probably look at giving the option of a LipiFlow or an IPL as far as these patients are concerned. A step 3, where the severity is more severe, you would probably look at shifting to an autologous serum or a therapeutic bandage contact lens, or more commonly a permanent punctal occlusion, probably with a cautery, which would try to retain the existing tears on the ocular surface and would try to retain the tear drop that the patient puts on the eye for a longer period of time. And in a very severe, you're looking at surgical transplant more for complications of the dry eye disease, or in terms of a tarsorrhaphy to try to reduce the surface area that is exposed and try to make the patient a little bit more comfortable. So this gives us a broad outline as to where we would fit each molecule that we have in our armamentarium as far as treating dry eye is concerned. Coming to the Dry Eye Society, which gave its classification of dry eye And it also gave something called as a tear film oriented therapy. Now, this is something which is new from an Indian context point of view, because here they gave a description of tear film based dynamics, which is different in an aqueous tear deficiency as compared to a mucin deficiency, as compared to evaporative dry eye. And then they gave suggested options in what would be the molecule of choice when you're talking about lubricants in each disease. So if you're looking at a lipid layer deficiency, you're probably looking at using diclofosol. If you're looking at an aqueous deficiency, you're probably looking at something like a sodium hyaluronate or a diclofosol or a rebepamide when it's associated with mucin deficiency also. And if you have primarily epithelium or mucin associated issues, you have the option of using diclofosol or rebepamide. And if you have ocular surface inflammation, you're looking at cyclosporin, steroids, or rebepamide. By and large, what goes across all this, the entire spectrum, diclofosol seems to be involved, whether there's a lipid layer deficiency, whether there's an aqueous deficiency, whether there's an epithelial issue, whether there's inflammation. Unfortunately, from an Indian point of view, diclofosol is not available in an Indian market, and we are waiting for Santen to launch it in the Indian market as such. But what is available out of these molecules here is probably sodium hyaluronate. And when you're looking at sodium hyaluronate, let's look at the properties. Nikhil has already mentioned it, just it's going to be a rehearsal of the same thing. To a certain extent, it can bind to about 6,000 times its weight of water molecule, and it does get retained on the ocular surface for a longer period of time, increase the corneal wettability, and it has highly good viscoelastic properties. So these are properties that you would ideally want in a lubricating agent. But in addition to that, it does have effects on the epithelium, as Nikhil has already mentioned. So when you have an epithelial healing issue, or when you have the epithelium which is not healthy, the sodium hyaluronate actually binds to the fibronectin and it facilitates an epithelial extension. And in this manner, it accelerates the wound healing. So in rabbit models or in animal models, they've actually shown that when you just give sodium hyaluronate versus any of the competitor lubricating drops, an epithelial defect which has been artificially created either by a blade or by using chemical tends to heal faster when you use sodium hyaluronate as compared to just a competitive lubricating drop. So what is the evidence that is available clinically that we have? So this basically study called as a breakup index ratio. Now, what is a breakup index ratio? It's basically a ratio of the breakup time after installation of the drop versus a breakup time before installation of the drop. So this difference is calculated, and it is done for patients who were given sodium hyaluronate and patients who were given a random artificial tear. And if you look at the graph for the first half an hour, both the arcs are almost the same. But after that, after the first 20 minutes, to be precise, the sodium hyaluronate group significantly has retained a better breakup ratio throughout almost for a 2-hour period. So that tells us that it increases the breakup time, and it is able to maintain it at least for a 2-hour period. And this maintenance is much better than what a competitor lubricating drop would give. And if you look at an absolute breakup value in terms of the non-invasive breakup time that you would get in these eyes, when you compare the vehicle alone of sodium hyaluronate versus the molecule itself, there is a significant improvement in the breakup time with the molecule, and this is much more than just the vehicle alone. So you cannot attribute the improvement in the breakup time just to the vehicle. There is a significant component of the actual molecule which is increasing the breakup time, and it is able to maintain it or sustain it almost till a 3-hour period. Even till a 3-hour period, it is higher. So effectively, this basically tells us that if you put a molecule of sodium hyaluronate on the eye, you would improve the tear breakup for a period of 3 hours. So to a certain extent, you can say that you can reduce the installation of drops in the eye, at least give a gap of around 3 to 4 hours, because you know that the molecule is probably going to stay in the eye for that much period of time. Again, this will depend on the severity of the dry eye that the patient has. Somebody who has an absolutely no Shermers will still need a higher volume of a higher frequency of lubricating drops. Somebody who has, say, a 4 or a 5 or a borderline Shermers will be much more comfortable just with a 4-time or a 5-time installation of sodium hyaluronate as a molecule. The next thing is, what is the subjective comfort that the patient has? And if you're looking at the subjective comfort, and this study looked at the symptom comfort in terms of dryness, grittiness, and stinging. And when they compared it at day 0, if you look at day 0, the both the study and both the groups tended to have the same amount of complaints. And as time goes by, day 35, day 84, the dryness component, the grittiness and the stinging seem to be significantly better in the group which received sodium hyaluronate as compared to the group that received CMC. Again, between the three symptoms, the grittiness and the stinging seem to be significantly better with sodium hyaluronate as compared to the CMC molecule as such. And more patients expressed their satisfaction with a 0.1% HA than with a 0.5% CMC on day 35 of treatment. So this basically tells us that even when you're looking at a patient comfort point of view, sodium hyaluronate seems to be performing better than a competitor 0.5% CMC drop alone. And if you're looking at objective parameters, so you can look at breakup, which we've already said, it increases the breakup significantly for a 3-hour period. And if you're looking at the next objective parameter would be the staining of the ocular surface. So you started off with a similar amount of staining in both the groups. In the group with 0.5% CMC, there is about a 56% decrease in the staining. And in the group with a 0.1% HA, there is about a 64% decrease in staining. Both the medicines would cause a decrease in staining because there is dry eye which is causing the epithelial issues, and you are addressing the dry eye, whether it is with CMC or whether it is with HA. But the improvement in the surface epithelial irregularity is much higher when you have used sodium hyaluronate as compared to a CMC alone. And at day 84, the reduction was significantly more in the group which got sodium hyaluronate as compared to the CMC group alone. So to conclude my talk, basically when you're looking at a molecule, you would want to ideally, or a tear supplement, you would want it ideally to replace all the 3 layers of the tears. You would want it to replace the lipid layer, you would want it to replace the mucin, and you would want it to replace the aqueous. Unfortunately, in India, we do not have a molecule which does all 3 like that, which is available in Japan. Sodium hyaluronate as a molecule does affect 2 of these because it does bind to the mucin and delivers further hydration to the ocular surface over an expanded period of time. It can hold on to the water molecules for a longer period of time on the ocular surface. So it improves the tear meniscus height to a certain extent. It improves the stability of the tears on the ocular surface by increasing the breakup time. It improves the ocular surface status by reducing the corneal and conjunctival staining on the ocular surface as compared to just a routine CMC drops. It improves not just the subjective symptoms, but it also objectively improves the ocular surface signs that we see in a dry eye disease. And it does have laboratory results to show that it does help in corneal epithelialization also. And like Nikhil mentioned, it does have issues with, it does have a role probably in some kind of a neurogeneration and in anti-inflammatory effects. So by and large, this is a molecule which has multiple effects. Yes, we would want it to have some amount of lipid also in it to give it a complete tear supplement package. But till we reach that, at this point of time, this seems to be a useful molecule in most patients with dry eye. I would like to conclude by thanking you. Thank you.
Thank you, Bhaskar. I think we do have a fair amount of time for questions. We do have some questions that have come in. Since we've been talking so much about epithelial health, and we've been talking about maintaining the epithelial health, the first question was, why is epithelial health important in dry eye disease? What are the problems that happen when the epithelium in a dry eye is not healthy? Can either Nikhil or Bhaskar take that, or maybe both share your views on that?
I think basically when we have a patient with dry eye, which is little bit more where you see epithelial breakdown in the form of fluorescein staining, you see punctate erosions. So these are the patients who definitely have more symptoms and they will have blurring of vision. And so basically, so these patients will suffer more than those who don't have the, staining in the eye. So that is why, and it indicates that probably the dry eye is, significant enough, or the grade of the dry eye is what it also indicates. So we would like to step up our treatment if the staining persists despite giving lubricant. So we need to go further in these patients and try to intensify whatever we are doing so as to allow the epithelium to regenerate and for the staining to come down. Maybe you can, Bhaskar can add some.
So basically, as the epithelial stippling is concerned or fluorescein staining is concerned, basically that's a precursor to finally developing an epithelial defect and having an issue with the ocular surface, which is going to be which is going to cause permanent damage to the ocular surface. So you would want the minor erosions to actually heal without the surfacing of the tears on the ocular surface will get affected, and that is primarily affected, and that is why the visual quality that these patients have is going to be much poorer as compared to a normal individual. So it's basically both ways. One is the vision quality, comfort, and third point would be we don't want them to end up with a complication of an epithelial defect or an infection secondary to the breakdown of the epithelial barrier.
I think we have, yeah.
Yeah, was I audible?
Yeah, I think the last minute
Hello,
we missed you.
I have a issue connection at home, and so basically we are looking at three points with respect to epithelial issues. One is the quality of vision, one is the comfort, and the third one would be if you end up having epithelial issues, there is a possibility of ending up with complications related to the dry eye with respect to either a persistent epithelial defect or secondary infections, which could be sight threatening. So you want the epithelium to be pristine. Sir, is there?
I think we have lost Srinivas also. He is also probably maybe.
It was.
So there is a power cut at this place.
Okay.
Yeah. So
yeah, I don't know if in Chennai there's a power cut. My house there's a power cut. That's why I'm going off and on.
Yes. So,
Okay.
So maybe request Sir Dr. Nikhil Gokhale to take over.
Yeah.
Go through the next question if it is there.
Yeah, can you give us the questions and we can try to answer them?
Yeah. So please check your phone, Dr. Gokhale sir.
Okay. Yeah, so another question that, is how should we implement fluorescein staining in our practice? How important is it? And some of them still feel that maybe it's time consuming. So what is the role of fluorescein staining? And maybe Bhaskar, if you can just.
I think fluorescein plays a very important role in evaluation of any patient. Every patient in your OPD, I would probably think just putting a drop of fluorescein in the eye helps you understand the ocular surface better, whether it is a pre-cataract patient, whether it is a normal patient. It just takes a couple of seconds. Unlike, I can understand if you don't want to do a 5-minute Shermer's because it takes 5 minutes of your time, but putting a drop of fluorescein, asking the patient to blink 3 times and looking at the tears significantly gives you information which is there. You can get an information like Dr. Rao has already mentioned. Your tear meniscus height is much better visible. You don't need any hi-fi gadgets. The flow of fluorescein on the ocular surface tells you an idea whether there is an aqueous deficiency, and the TFOS group has already showed a significance of different patterns of breakup. That's a little bit difficult for a general ophthalmologist to understand. I do agree, but at least the basic ATD pattern where there are linear streaks or there is a spontaneous break is very easily appreciated with fluorescein stain. SPKs on the surface might not be appreciated unless you stain. If you are very careful, you might see that there's a lackluster appearance in the cornea. But for you to pick that up, you have to actually look for it. And fluorescein makes it easier for you to identify that. So when something makes your task a lot more simpler with just 2 seconds and 1 rupee cost, I think it is a very useful tool. I wouldn't advocate doing all the hi-fi gadgets for every routine patient unless you are probably you have access to them and the patient is affording the cost, and or if the patient is not getting better with whatever treatment measures you have and you have to investigate the patient further. But for a routine patient, fluorescein staining plays a very important role in not just dry eye evaluation, across board in all the ophthalmic investigations. And the other point is, it should ideally be done before you do your AT, before you dilate the eye, because all these dilating drops also can cause staining on the ocular surface, which you could misinterpret.
In fact, I think it's much faster and easier to do than a Shermer test, which takes 5 minutes of patience. Another question is that what are the common ocular conditions where the corneal surface would be compromised and hyaluronic acid would be better suited? So maybe I can just add a little bit and then Bhaskar can speak on this. So in fact, we had a webinar some time back where I tried to look into these conditions. So despite the fact that, of course, hyaluronic acid is very good for dry eye patients, there are several other ocular surface conditions where the ocular surface is compromised and where I feel that probably we should try to use this drug and see how it works. For example, a patient who has a corneal abrasion where the epithelium is to heal, a patient where you have done surgery, for example, a PRK, or you have done a pterygium surgery, or you have done a corneal graft, situations where the epithelium is compromised or the epithelial defect is there, which is created at the time of surgery. I think in these situations, probably we don't, we just sort of write any lubricant that comes to our pen. But when we really go through some of the data as we did today, I think we need to realize that there may be situations, again, a very common problem in practice is diabetic patients. Now, we need to understand that diabetic patients have significant problems on the surface of the eye. Their epithelial basement membrane may not always be that healthy, and their corneal nerve and innervation is not healthy. So there are several factors which might, lead to ocular surface problems such as corneal staining, epithelial staining. So there specifically, again, this drug might be useful. Similarly, when we have injuries, recurrent erosions, there are so many situations where the epithelial problems are there, where I think we should be trying to use this medication. There are some published studies, but I think our own experience in these conditions may be something that, should guide us about using sodium hyaluronate more often in ocular surface disease, in addition to, of course, using it in dry eye conditions. Bhaskar, you would like to add?
Primarily, you've covered most of the things. What happens most of the time is when you have to give any patient any post-operative medication, the lubricating drop by default becomes one of the medicine that you are giving the patient. So we don't normally actually apply our brain to it. It's more of a spinal level. Okay, it might be 1 CMC or it might be whichever brand CMC or HPMC or HA, which you feel you want to give on that particular day, or your resident advises on that particular day. But when you're looking at published literature, sodium hyaluronate does seem to have a better epithelial healing issue. So if you are dealing with the epithelialization of the surface, then you would probably think that you would need to use sodium hyaluronate rather than just using a lubricating drop. Decision whether you would want to use a lubricating drop at all or not is up to you. I mean, obviously, if you you have to give the patient 3 medications, the lubricating drop becomes the last of the 3 medications that you would want to give, unless he is a coexisting dry eye patient. Suppose it's a patient who's just had a pterygium surgery. Your first medication of choice is going to be your steroid and an antibiotic for the defect. So if you feel the patient is not going to be using too many medications, you stick to the first 2, which is most crucial. But if you're giving a lubricating drop for a patient who has an epithelial defect, it might make sense to actually use sodium hyaluronate. Having said that, we've actually not analyzed our own data in a sense, in a very methodical manner to say that, yes, we have used HA in these many patients and it has got this result. That's something as institutes and as private practitioners, leading private practitioners, we should probably be looking at least doing a small pilot study from our own basis and trying to prove what is written in Western literature and being sure that what we are getting in India is similar to what is being published outside.
I totally agree. There's also one question that if a patient has dry eye disease with a lot of screen usage, the computer vision syndrome sort of thing, then what molecule should be used? One of the question is.
So basically, when you look at a patient who has a computer vision syndrome, or when you're looking at a young patient who's very, very symptomatic, and you don't see much of staining on the ocular surface, these are patients who either have an MGD component, whether it is, you call it computer vision because they are working on the system, but even if they don't work that much on the system, we've also noticed that these are patients who tend to have orthoptic issues. So when you have two small issues, an orthoptic issue and an MGD, they tend to become a lot more symptomatic, and they are at that phase of their life that they want everything to be very comfortable for them, and they are not ready to accept any kind of discomfort here. So it is important to, one, identify that it's an MGD or it's a CVS which is causing a problem, and tell them what they have to do to address those issues. In terms of molecule, any molecule which increases the breakup of a tear breakup pattern for a longer period of time. So I would probably look at PG or a sodium hyaluronate group of molecules which increase the breakup much more than just a CMC. If I have to use a CMC or an HPMC, I would probably use a higher concentration CMC, HPMC. But then sometimes when you increase the concentration, there is a transient blurring for a couple of minutes, which the patient should be aware, and he should be ready to accept that. With HA and with the PG, the blurring is not that much that we perceive, at least as far as what patients tell us.
Right.
I think basically with these people, I think we're looking at more of an evaporative dry eye, because these are young people with healthy eyes. So they don't have an aqueous deficiency component unless something unusual is happening. It's the act of staring at long hours at a screen, which is unphysiological. And studies have shown that your normal blink rate of about 16 or 17 can come down to 4 times or so when you're concentrating on a screen. When you do this for hours at end, particularly if you're in a low humidity air conditioned room, or if you have the breeze set up wrongly so that the AC is blowing in your face or under a fan, then you get an evaporative dry eye component. So then you basically have to address that aspect of it. Like Bhaskar said, the environmental condition and things like that, learning to blink more often, taking little breaks when you're using your computer, and use a drop to support that evaporative component as well. I got locked out because of a power cut in between when Nikhil was answering the first question about the epithelium. I'm not sure exactly what he covered. So I'm just going to add a couple of points. I think that question is very important, because the whole focus of this meeting is about the epithelium and dry eye disease. So when you have epithelial damage, and the main pathway by which that happens in a dry eye disease is the hyperosmolarity of the tear film. When you have a hyperosmolar tear film, it stresses the epithelial cell, and the stressed epithelial cell releases a lot of pro-inflammatory mediators. So these can basically bring in a lot of the inflammatory cells, the lymphocytes and so on and so forth. They escalate the process by releasing their own inflammatory cytokines, and all of this causes damage again. And this damage will further release more inflammatory cells. That is what I mentioned in the beginning slide about a vicious cycle. So if you have a healthy epithelium, you can cut this off at the base itself and prevent the cycle from escalating. The other thing that happens when you have an inflamed epithelium is it produces what are called corneal envelope precursors. And these are known to produce keratinization of the meibomian gland orifices and the ductules through which the meibomian gland expresses its secretion. If you have keratinization, obviously there's a block that occurs. And then one, there is not enough oil that's coming onto the surface, and the evaporative dry eye component increases, and that produces desiccation, and further visual cycle goes on. And over time, if the glands get blocked, the fluid cannot come out, the meibomian fluid, there is back pressure, the glands atrophy, and you're basically recruiting meibomian gland atrophy and dysfunction into the process. So whoever asked that question, I don't know who it was, but it's a very important question. And that is why this entire session has been focusing on trying to keep the epithelium healthy. Because if you could do that, you can terminate a lot of these molecular pathogenetic mechanisms that are setting up further and further damage right at the start itself. So I think that's a good question, whoever asked it.
So we have one more question.
Yes.
Is there any role of lid cleanser form in dry eye?
Lid cleansers, is it?
Yeah, lead cleanser forms in dry eye.
I think that is what Bhaskar was saying, that over time in a dry eye, there is inevitably a recruitment of the meibomian gland process. In my days, when we started doing this 30 years ago, we used to call it the triple S syndrome. There is Zika, Seborrhea, and Staphylococcus. So whenever you have one, the other two generally come in over a period of time. And that is what we have learned We've been able to understand the pathogenic mechanisms, and I showed you those 3 vicious cycles of inflammation, dry eye, and MGD. So when you have one, the others will come along inevitably. So if you see significant lid margin disease, then obviously you would want to treat it. And lid cleanings, lid cleansers, there are various wipes that are available. And in the US, they have tea tree oil impregnated, wipes that you can use if you think there is Demodex. So depending on the pathology in the lid, you can clean. So all lid disease, again, is not one animal, just like all dry eye is not one. You could have aqueous, you could have you can have mucin, you can have lipid. So you can have different components. So similarly with the lid margin disease, even though we club it under meibomian gland dysfunction, there are effectively 3 types. One is the meibomian seborrhea, which is by and large the commonest, where the lids produce excessive amounts of that oily product, which comes into the surface and then basically contaminates the surface of the corneal epithelium, prevents the aqueous tears from working. The second component is something called meibomianitis or meibomitis, where you have frankly inflammatory material coming out of the meibomian glands. The easiest ways to distinguish this is to put your thumb on the lower middle third of the lid and give firm pressure. And then the thumb usually will encompass about 4 or 5 of these gland openings. You will be able to see how many of the glands actually produce a fluid. If only 1 out of 5 produces, then that's the last kind, which is the sicca, where the gland openings are all atrophic and closed down, and they're not producing any oil onto the surface. So when you put this thumb and put pressure, you see how many glands are secreting fluid. You see the quantum of fluid that comes out. In a healthy eye, you should just see a small bead of clear fluid. And the third one is the amount of fluid, the quality of the fluid. So when you do this, you can judge what is happening. So depending on that, you can do lid margin scrubs, you can do lid massages, you can use macrolides, you can use anti-inflammatory. Sometimes you subject them to conditions like the lippy flow, where you're trying to get the lids to express the oil out, or you can do the light-based therapy now if the quality of oil is changed. So again, like dry eye disease, we shouldn't get into the mindset that dry eye disease is one teardrop. Lid margin disease is one approach. So you have to figure out what is happening and then mix and match your options. I think, Nikhil, one question that I came to my mind is when we talk so much about hyaluronate, it's actually not one question, it's 3 questions. There are some drops which combine hyaluronate with another demulcent, like CMC. Yeah. So the question for you is, what is the pro and con of doing this as opposing to using hyaluronate alone? The second question is, sometimes when people have dry eye drops, they often use them every half an hour, every 1 hour. I have patients using drops every 10 to 15 minutes. Now, is hyaluronate a drop that lends itself to this kind of usage? If you're giving it as a dry eye drop, if he starts putting it every 15 minutes, is that good for him? Is it really making no difference? It's just waste of medicine? Or is there anything that is not good about that? And the third question is this your first line medication? So if somebody comes in with dry eye related symptoms, is hyaluronate the first medicine that you would go to, or do you keep it back for certain conditions? I've actually asked you 3 questions. I'm sorry.
So I think I'll answer the second one first. So basically, I think we have, with a lot of interaction with our Japanese colleagues, of course, with the help of Santen, we have realized that because it's like a sponge which stays on the surface, as I mentioned. So basically, it will also trap a lot of inflammatory cytokines, especially in an eye which is inflamed. So that is why possibly if you put it every hourly, it probably may not be a good option. And the recommended dose is maybe 4 times a day or 5 times a day at the maximum. So in fact, we also see that it tends to maintain the tear film for 2 to 3 hours. So what I've started doing after, coming to know about this particular concept is that I sometimes combine drops. So I would give a patient a hyaluronic acid 4 times a day or so. And if the patient is such that he requires a lot of drops or the dry eye is fairly bad, then I combine it with another polymer. So maybe if I give him 0.5 CMC, which he can put maybe more number of times, and then in between use this hyaluronic acid 4 times or 5 times maximum. Because very frankly, initially when even I would have used it probably hourly without knowing this, idea or this thought process wasn't there with us. So we have been doing that way. As regards the combination of CMC and hyaluronic acid, or we have with pantothenic acid, and so many preparations are available. I'm not really sure whether we have data but I would rather prefer use them separately rather than mixing up everything, because again, many of these patients where we use these polymers are the ones where they have more severe forms of dry eye. So possibly use them separately so that you can use at the correct frequency. And your third question was regarding what did you?
No, whether it would be your first medicine, go-to medicine. I think you
Okay.
answered that when you answered the second
Yeah.
question. You said you would combine it with something else as well.
Yeah.
And Bhaskar, the other question was, we talked about its sponge-like properties and its improving the tear volume and retaining hydration and so on. One of the important factors with teardrops is the blur factor. Nikhil briefly mentioned it. So is hyaluronic acid, when you use it as a teardrop, does it cause a lot of blur, or can the patient use it and continue with its work? How long does it take for his vision to clear, or is there no blur at all?
By and large, at least with the concentration of 0.18, the blur is not that much of an issue as such. Most of the patients don't complain, but obviously you will have that occasional patient who does complain of a little bit of blur, which clears off in a couple of minutes. With a higher concentration, it's always a trade-off between the concentration, the viscosity of the molecule, and the spread of the molecule on the surface. So that 0.18 seems to be having the best of both, where it is able to stay on the surface for a longer period of time, as well as not blur the vision as much as compared to slightly more higher concentration of the same molecule, which definitely has a blurring effect.
So based on this, you would think that the ideal concentration for hyaluronic, which hits the sweet spot between the duration of stay and the blurring, is what? What is the ideal concentration, you think?
I mean, I would probably think 0.18 or 0.2 would probably be a reasonable choice between.
Because there are drops that are 0.3 as well.
0.3
So
also.
you probably think that the blur factor would be a lot more.
Yeah, because even with 0.18, you do have that occasional patients who do complain of blur, even though the company says that they don't have blur and we can use it on the contact lens without any issue. But there are occasional patients, but it's very minimal. And again, you have to also look at the patient profile and how sensitive they are to the discomfort and the blur with each medication. So you have to take that with a pinch of salt.
There's another question about how fluorescein staining can be implemented in practice, about the time constraints. I think the whole idea of doing the talk in the first session was to talk about fluorescein staining, because it's like I said, very cheap. It's very easy to do, and it doesn't take any time. I mean, all of us have been using it right from the first year of our postgraduate training. So the only key points with that, why we did this talk, was to do it the right way. If you put in either too much of fluorescein or too little, you're not going to get your basically the answers that you want. So you want to put in the correct amount, so that small little amount, allow the dye to disperse through the tear film, and then quickly look at it within the next minute or so. If you leave it for too long and there is some pathology, it goes in and then diffuses through the epithelium, and the pattern of staining changes, and sometimes that will confuse the picture. And then when you do pick up the staining, it is important to categorize it in terms of where is the staining and the quantum of staining. And if you did all this, and if you start doing this routinely, it takes hardly 2 to 3 minutes, I would think. I don't think it takes longer than that. And it does give you a fair bit of information. Of course, if you have access to all of these fancy gadgets and you're able to get each of these components separately, we're not saying don't do that. I mean, that's also fine. But since many of our clinics in the Indian context don't have access to those devices, we didn't want people to go away from the session thinking, oh, if I don't have all that, then I can't do a good dry eye practice. I don't think that is necessarily true. So I think fluorescein staining is something that each of us can easily and quickly and simply implement. And just if you understand a few basics about it, we can get a lot of useful information from it. So I think that was one other question that I could see. Any other questions that have come up? Is anybody?
One other important thing was that patients, we need to remember that patients who have extremely severe dry eye with very little tears on the surface, then there can be that quenching phenomena, which, sometimes you might just see a black sort of surface because the fluorescein is not diluted enough, or there are no tears which are normally there in the eye. So in these patients, how should we do, Srinivas?
So either we can wait for some time, because the act of stimulating the surface by putting that, obviously I've seen people actually take the strip and rub it on the bulbar conj and all that. I don't think that's a good way to do it at all. You just pull the lower lid down, and in the outer border of the lower lid and the temporal border, you just touch that wet fluorescein strip. Luckily, fluorescein elutes out of the strip very easily, unlike rose bengal or fluorescein green. So just a small amount is enough. And that stimulation will usually cause some tears to come in. So that is why you wait that 1 minute. In the first instance where you put too much, you're waiting 1 minute for the excess to go away. In the second instance where there's not enough tears, you're waiting 1 minute for it to come in. And if it's that bone dry and you're not getting anything, then you can always increase the little quantum and put it in a second time. As long as you recognize that the blackness is not a lack of staining, but a lack of dye, then you'll be, in a position to handle that. And there was one more question from Dr. Mrinmayi. She was wanting to know about what are your thoughts about, I think she's asking about polyethylene glycol and what about that, the PEG-based drops? Where do you think they stand in the armamentarium of our tier products, and where would you consider them as your first choice? Maybe Bhaskar, if you have any thoughts on PEG.
I think
Propylene
PEG also
glycol
has
and polyethylene
properties.
glycol.
Yeah. PEG also has really good properties with respect to at least replenishing both the aqueous component and to a certain extent having a mucomimetic effect on the surface as such, but probably doesn't have the so-called anti-inflammatory and the epithelial healing properties that sodium hyaluronate proposes. Between both, given a choice between this versus that, I would probably think the difference is marginal. If the patient is already using a PEG PG drop, I would ask him to just continue with the same. If the patient is on a sodium hyaluronate molecule, I would want to ask him to continue with the same. There is no significant difference unless you're looking at the epithelial healing being more critical. Then maybe sodium hyaluronate scores slightly more as compared to a PEG PG.
I think the question she asks is because many of these products, we're not naming products here, of course. Many of these PG, PEG products tend to be added on with HP guar, which again, like you said, increases the inherent mucomimetic properties of the PG, PEG. So in somebody who has something like an evaporative dry eye where the water is not staying longer on the mucin, or we have a mucin deficiency state, because we don't have diclofosol with us at the moment or rebamipide with us at the moment, which would be the ideal agent to use because it increases the mucin production, then we can go the other way and use something that simulates the mucin on the surface, and then the HP guar based big PG and PG drop might be a good idea. But like you said, if there is evidence of also epithelial damage, then maybe hyaluronate would come into its own because it definitely has some epithelial healing tendencies like we've been saying. So depending on the component of the tear film which is affected, depending on the changes that we're seeing on the ocular surface, you may want to mix and match and choose rationally among the tear products that you have. And that's the whole idea of this exercise. We don't want people to go away thinking dry eye disease is one entity, responds one medication, and that's all it is. It's a little more complex than that, but it's not too complex. If you understand the basics that we've been talking about, it's very easy to get the rationale and then apply the drops appropriately. Any other questions? I think we're almost at the end of our session. Shweta, I think it's time to wind down, is it? Yeah.
Yes.
Yeah. So
Thank
we'll
you
let
so
you do the
much.
honors.
Thank you so much, sir. Thank you, sir. Thank you, Gokhale, sir, and Bhaskar, sir. It was quite delightful hearing you, and it was quite informative and very basic. Even I could understand it, a lot of things. Thank you so much. And with this, I end the discussion and end of the day. We now announce the closure.
Thank you very much. Good night,
Yes.
everybody. Have a nice weekend.
Thank you.
Bye-bye.